Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist, and I'm here to help you find your airway answers. We're in this together. Let's do this. Let's get into part 2 now and go ahead and let's start talking about the second half of this wonderful information.
We have a lot of articulations, and when we study them and we learn them and we name them, almost always, if I quiz a colleague, like in a teaching moment, they'll forget the other maxilla. And so you hear even different people in your conferences talking about the maxilla. It's the maxillae. And I really think it's important to be reminded of the two halves, because even when we look up the nasal chamber, there could be one side where the turbinates and so on are different. The nasal cycle is different on the two sides, and the deviated septum may make a difference on what happens on one half. So a lot of things are different on each half of the face. When we look at intermolar width, which is valuable at the age, I just want to make a point that we should know that in the brachy or the wide faces, whatever is the average number, is supposed to be about 2 millimeters more than the mean. It's a mean because it's that average of the widest and the narrowest, the central number. But the brachy number is actually 2 millimeters wider. It should be wider than that number, but the dolical is actually 2 millimeters narrower, is the norm for that subgroup. So sure, put them all together, you've got a number, and that's useful. But in your mind, think a little bit more beyond that. And then a reminder that we're going to expand when the teeth are young. And if we're going to help the asymmetry of the midface, getting in there earlier, we can do much more to make that symmetric, just like on our daughter Jenny, in her case I showed. So when we do SPE, the arch comes down and forward. So I showed that already. And same later in treatment, it'll come down and forward. But I don't want to put chains on across the front teeth and make them tip in. I want to keep the front teeth prominent and forward. So we don't just run these elastic chains around the arch hardly ever during treatment. We keep the arch wide, we keep the jaws forward, and we keep that big wide arch perimeter. So it's not just the width, it's the whole perimeter. And as we widen, we gain about 1/3 of a millimeter of arch length with the millimeter of perimeter. So a little bit of width gives us more perimeter of the arch, more space for teeth. So there's a benefit there. The teeth can now stay forward. We can gain space in between along the side and make it all fit. We know from sleep medicine that the kids that are snoring, that have small jaws, they need to have some kind of maxillary and mandibular orthopedic widening, but also forward placement. If the front portions are all brought forward, way at the back in the pharynx, that area, if it's displacing forward, we're helping our airway and our adenoid region. It's not a substitute for a procedure. I'm just saying if there's a grade 1 or grade 2 situation there, let's get our therapeutics going and orthopedics going. We might actually be able to shrink that and overcome that without actually surgical intervention, even though we highly favor that. So in this stage of it all, we might have width and have the incisor replacement, and it looks like we're out of control. The upper looks forward, and the dentist looks at it and says, wow, I don't think they know what they're doing. You've got more gap in the front now. But notice the lower front teeth have all compensated in because of what the lip pressure was and the hypermentalis. But now we can overcome that, upright the teeth forward, and end up with the final arch as an adult being this forward projecting arch that we call beauty too. And so we want smile projection. So when we look at angles, and even on aligners, we do this with all the anteriors. We bring them forward with adding torque features on all the anterior teeth, some more, some less, based on what the need is. So we individualize the aligners with torque control on anteriors. And yes, we open spaces. Case was presented in the 80s already in cases because we were considered a little bit radical for opening up spaces. And yet this was a lady who snored a lot and she had sleep apnea. We didn't quite know it the way it is now, but her history had things, and her husband wanted help and she was tired all the time. So we reopened the upper spaces and then advanced the lower jaw. And she came back 10 years later, was just a happy woman, happy life. And so I'm making the point, we were kind of doing these things back then. And I even remember having the privilege to be at Minnesota's orthodontic alumni meeting in the 80s lecturing, and Bill Hang actually was in the audience. He had flown in from, I think, New Hampshire, somewhere out east. And so this was stuff we're doing then. So we're in step with that. I remember a similar meeting. You had Brian Hockelon, did a nice job, beautiful presentation. And Brian's dad had us for a meeting in Arizona. And Brian was a new practitioner in that group. So the things that are being done to open spaces in the right face, not every time, but in a face that needs that, then we agree. We're doing those things too. So I want to credit back to people I'm have learned from. Ricketts and these people were doing those things. So I did those in the 80s too. But I credit all these people that went before for having done those things. I wrote articles on non-extraction for the upper arch, lower arch. These were in the World Journal about 20 years ago. And it's making the point that we do these things early and we favor making room for all the teeth, but developing the jaws so the teeth have the proper structure and support. We do it with slow expansion, and this is sleep journals telling us that. Sleep 2004, supporting doing that. So that's 20 years ago. For every 1 millimeter width, we get about 2.3% nasal volume increase. That's Mocho's research at Boston U, orthodontists. So I had the privilege of being on their program a few years ago. I saw this research. It's very powerful that 10 millimeters, 15 millimeters of width, intermolar width, with the nasal floor changing, look at how much more flow we get for the airway. So I showed this already to emphasize that's the benefit, and that's the benefit. And then the dynamics, the fluid dynamics are that it's a smooth laminar flow, not the turbulent flow. And that's what this all means. So we're going to change the flow. There's another screw design to consider, fan screw. So we get much more width across the mid part of the arch and again, make more room for the teeth. So this screw and this design, this case is showing what gets done. And then here it is close up. There's many companies make it. I think Great Lakes has the nicest design. Leone has a beautiful design. But look at how much width we get up in the mid portion as we use the appliance to reshape the arch. And then again, a case that if it was done by classic orthodontic measurements, there would have been teeth taken out because of the degree of crowding. And yet we do all this and it opens up the airway and gets that nice full arch. And even if it's a surgical case, we can still use this to widen the arch before we move the jaws around. And if I want one side to widen more because of what I'll see on the frontal analysis, the coronal view, I can add acrylic in the palate, as you see in this example, fan screw plus acrylic. So the one side of the mouth will widen more because the opposite side is using palatal anchorage. And today we might use more TADs for this, but still TADs might tend to push both sides out. And I want one side to move before the other. I'll show later that we'll do a surgical release in some of these cases on just one side. So that side slides out and the other remains as anchorage. We might put acrylic on both sides of the expander to use the palatal shelves to push out to get more nasal floor development. Because this kid is older, they're getting permanent teeth now. So we might modify the design of the expander for the nasal benefit. There's another design. Obviously, this is when we get into adding TADs now to get more structural change, because you can see how tapered that arch is. It needs to be widened through the midsection. So a better design on this one, they transferred in, weren't happy with some things. So I changed the design to get that mid part wider. And you can even have double screws so that you can turn one screw more than the other. You're not controlled by just one screw. You can have the front screw be turning every day or every other day or every third day, and the back screw just twice a week. So you get more net change up in the mid part than you do at the back to reshape the arch. So by using two screws and then modifying the turn schedule, you'll get a different outcome. So like a case like this, we want to widen near the canines and have the teeth nicely fit. Along with this, I've mentioned using the utility arch to the four incisors to lift and advance them into place, and at the same time be widening the arch and moving the molars into place. And somebody who doesn't understand this would say, oh, that's retractive techniques because you're pushing the molar back. The whole complex is being held forward, the teeth held forward. And if we want to move it forward more, we'll put the face mask to this. So it's making room within the arch, changing the perimeter to make room for teeth, relocating the incisors to get more space for teeth. So all the side teeth ultimately can be fitted in, not extraction, and so on. And then at the end, the smile is forward and it projects. Okay, on the kids, these are the 4 kids years ago, young and then as adults, and different facial patterns as you've seen. But Bill's got all 32 teeth, had all the airway stuff, had 3 phases. I believe in 3 phases when it's important, when it's appropriate. The deciduous phase, and then the late mixed dentition phase, and then the final finishing. And so Bill had 3, and Christy, in number 2 on the left, had 3. Katie had 2, and better airway, but more of a tapered face. And she had her upper second molars out. So I could take a tapered face and fit all the teeth in and use the third molars as second. So I used that technique on her because that's another controversial way of doing it. So I'm showing different thinking in our own family because they're individualized. Then young Jenny, all the teeth in and a big wide face. And so then Trudy is the one I credit for all this. So that's where the beauty comes from. Okay, so then let's go some more with template. The upper is a template, so if it's being widened, the lower has to be widened to match. And the upper is the template. So I don't just widen to make the upper fit. The lower has to be made optimal and decompensated. So I remember I've said that for years because my periodontal friends would criticize this. So I never would call it expansion, it was always decompensate. So that term has kind of caught on a little bit, and I'm glad because that describes it. But even on the adult, the non-grower, we're going to decompensate the arch, gently bring it to be upright, but we gain room for teeth that way. So the 𝐃𝐈𝐒𝐂𝐋𝐀 gets looked at first. And here's an example of an adult with a 𝐃𝐈𝐒𝐿 who was told she needed teeth out because of the crowding, even though she's missing some teeth. And she wasn't liking that opinion, came in. So I showed her that, we don't need teeth out, but let me walk you through what we really need to help your profile. And she snored and she didn't like that. And so long and short, the lower 𝐃𝐈𝐒𝐿 needed to be uprighted, as you see in the lower left view. All the teeth are nicely placed. And then I have to trust and verify. Top right screen, I want to verify, what did I do? And she had a severely degenerative right TMJ condition. The condylar process is resorbing. She had a lot of crepitus, a lot of low-grade inflammation. She had asymmetry to the short side because that becomes shorter anatomically. The eminence was modified. So we got that managed with our conservative therapy. Back then, I would sometimes do injections of Amvisc, or it's like a hyaluronate material in the joint. And so there's things we can do like any orthopedic doc would do. And so anyway, we got that controlled and then got the arch wide, as you can see here, and brought lower jaw forward and verify the lower right side, go back and superimpose what really changed. And you can see the right condyle is not changing. It's postured forward. Arches are wide. She's comfortable. She likes her smile. And how much do we bring the jaw forward? We bring it to the nasal vertical, the subnasally vertical, which is that yellow vertical line. And the chin should be on it for brachyface. She's a mesoface, so she should be 2 millimeters behind it, just slightly behind. She's got a beautiful profile, but if we brought it a little bit too much forward, it'd be too strong. So that gives us the harmony and the beauty of that lower facial part. So again, to remind us, brachyface, the chin's on, but the mesodolical is just slightly back in the visual norms. And so she has a pretty outcome, and many factors have been resolved. Okay, so then more common on this 𝐃𝐈𝐒𝐿. So the lower is compensated, and lower left screen shows you an arch that wasn't treated, but how severely compensated it is. And how's the tongue supposed to fit into that? So the tongue is laying up over the teeth and displaced, and the patient mouth breathes. We want that tongue up fully into the palate. So one of my first things, no matter the age, is going to be changing that lower arch dimension and uprighting the arch. So the top right side, lower right side has flea appliances, fixed lingual expansion appliances. The lower left is a spring-loaded Arnold appliance. And these are very simple They are slow and light force. They're useful on the 4-year-old. They're useful on the 30-year-old prior to aligners. They do a lot. We make wide loop lingual arches. I designed this thing back in the 80s and 90s because I could activate that big loop to keep advancing the incisor as they grow and develop. But also it lets the dentist get into those deciduous tooth if they have to remove a tooth because it's not exfoliating or have to restore. That tooth is accessible without me taking the appliance out. So the design is very versatile, useful. I've designed a double lingual arch and used it for years, but the loop, the small loop, can be gradually activated every 8 or 10 weeks, and it lengthens the arch, and the lower teeth go with it. And gradually we make room along the side for the teeth to fit as they erupt. If it's asymmetric, we can put the screw to one side, because if it's more teeth being anchored to, the side of less teeth will push out more. So the side that is narrower, the screw gets put to the narrow side, and the rest of the arch is anchorage to push that one side out more. Both expand, but one will go about 2/3 compared to 1/3. So we do asymmetric arch development. Okay, this is another example of using the appliances, but I'd much rather get into this case when they're 4 to 6. But if the lower is being changed, obviously the upper is being changed because the upper is the template. So the series would be the expander with loops to the molars to make arch length, locate the anterior teeth in the right place, bring the lower width out. So in the end, both arches are wide. He's got this big, wide smile and functional face. This case came in by Telly rather recently, but it's basically to show the upper arch was being expanded. The kid has a lot of nasal issues, myo issues, other issues with allergies and so on, but it was shared with me to ask what else can we do? And you notice the lower arch wasn't being treated at all. The upper was done. He's told that's you're good till your teeth come in. And I don't quite agree. And the history is loaded with yeses and responses and sleep problems, snoring, all that, mouth breathing still. So a lot of things are resolved, but look at the lower arch. If that lower had been uprighted, then it adds to the amount the upper would have to expand so that we get both arches much wider, nasal chamber wider, room for the tongue. All these things are made better by giving more attention to the lower. So we need bimaxillary expansion, upper and lower. And at Stanford, this was a study put out by Stacy Kuo and 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐿𝐿𝐿. So it shows that we need to bring both arches wide and do it early. And so I'm glad for this because it supports what we're doing. But we do this later too. If the patient hasn't come to us early, we're still going to bring it to the width that's optimal. Okay, so it's airway focused orthodontics. So again, here's a nice, not a nice, this is a narrow arch, obviously, and we've got teeth that aren't even in the arch yet. So we're going to use designs that give us width, but I want to try to get width and length so the teeth have a place to fit. So the three-way expander has been around for a long time. I've modified it a couple of times because it used to have bands to hold it, then it became bonded, and there's a preform even from Leone, but the point is I want something to go wider, but at the molars, I want to be able to activate these springs to give me length. And we all know in any class 2 malocclusion, the molars are rotated forward and need to derotate back. And when they derotate back, we get a lot of space. So you can see the space that's been created here, almost enough for another premolar. But what I've got to do is fit the canine in. So there is another tooth to fit. And these are published for anybody interested. There's also a version that's AP. So I can add a acrylic to the palate and then anchor it against the palatal bone. And as I'm getting development in arch space, arch perimeter, I've got room for teeth. So if I need a lot of width, this is not the one to use. If I need a lot of width, I'll use the other three-way. But these are from Great Lakes Dental Technologies. There's videos, we've done 9 videos on using these as pre-aligner appliances. Do all the widening, the arch development, the lengthening, the perimeter, get all of that done first for a few months, and then the aligners are easy. You don't need as many aligners, the case goes easier and faster. When I'm doing this, again, it's like flying a plane, this tip down roll. So I can activate one side more than the other. And almost always I'll alternate, activate right, next time left, right, and kind of walk it back and make room for these teeth. And at the same time, be relocating the incisors up in place. Jim Hilger's my good friend the whole life. I've learned a lot from Jim. I appreciate this guy. A lot of fun too. But Jim has done great things with different appliance designs. So you could use the pendulums, appendix, and do similar things. So I highly endorse what Jim does and all these things. One of the brightest thinkers we've got in orthodontics. We'll put occlusal rests on to anchor it. We put a safety tie so it keeps in place. I hardly ever have one come out of place, but I just don't want to risk that there would be a spring come loose. And so it develops the arches, and then we get to a point where we can jump out of that and finish with the aligner. So this is how the arch looks with the width. The springs have given me length around the molars and space, and now I can go ahead and bring the other teeth into the arch. So it shows the process of using that for all the orthopedic reasons. And then when it comes to the arch alignment, that's the easy part. And the other part's easy too. It's more fun doing the orthopedics. And so we get these nice big wide smiles, but the kids are totally functional. And these are three sisters. And so it's, they have smiles that just have projection and life. So I like that. So again, we've developed the maxillae, but the sutures that surround and attach to are altered. Okay, and then when can we do this? If we look at textbooks, let's look at the classic textbook that most residents are trained with. This is Prophet's text, and it's his chart of when the arches are supposedly unable to be expanded. And so you see it, females, he's saying at about 12, you can't do any more of the arches, males 14, as they're mature, and that's it. And after the suture fuses, no skeletal expansion in his textbook. So I got a red line through it because we're going, oh, wait a second, we really can change this a lot. But also, if you look at other publications, this is Handelman, and there's other publications, textbooks that talk about age of sutural closure. And notice in males how much older these are, and not even applicable in some of the females. We're not even sure. So look at how these are in the 40s, the ages 30s and 40s. So if we take these patients and we think about putting TADs in and MARPs and SARPs and doing these things, there's still a lot of opportunity, whether you're following Prophet's belief of sutures closed or not. We can do things. But we're not going to just start pushing the arches out, because things happen on permanent teeth that don't happen on deciduous teeth. The alveolus doesn't develop the same. So the teeth get pushed out. So we need some help. So we need to get some palatal anchorage, some other anchorage. So the designs, the top left, that's a Great Lakes expander. I think Mariana for the right side example, and then others, ours on the left, and then other ones, Juan Hulen and his wonderful work and the expansion that comes with his things. The other alternatives, they're all MARPs, and we subscribe to those, and we still use SARPs. It gets more severe cases, and we're going to add the ability to section the parts for the expansion before we even move the jaws forward or anywhere else. But we can make incisions on one side. So you can see on this occlusal view, I've had the surgeon do a relief incision parasagittal. So it's off to one side, and the alternative would be a parasagittal incision, two incisions to permit each side to slide out. And you could go right down the middle, but the bone is thin and easy to get through by going off to the side. So we do parasagittal. But this patient had a tooth out on one side, so I want that side to expand more. So we did a release, do the expansion, and she widens out. So it's asymmetric expansion. If I want asymmetric expansion, but I'm not having an incision in the palate, we can go above the apices of the teeth. And what we do is we have the surgeon not cut through the piriform on one side completely. So the surgery is done around the arch above the roots, all the way on the other side, drop down through the pterygoid, the buttress of the maxillae near the pterygoid plates. But anyway, by cutting both sides free, but leaving the piriform, when you start the turns, everything starts expanding, but the piriform is resistance and anchorage. So the other side starts moving out, but this side is delayed. And then after 10 days or so in office, we have the surgeon just do an incision, a bone burr, cut through the piriform, and then continue the expansion. So maybe the first part gave us 2 or 3 or 4 millimeters on the deficient side to catch it up. And both sides are now deficient. We push them out to the beyond, about 30% beyond, and then let that relax and heal in. But it gives us asymmetric net gain by having done the piriform procedure. And so we'll go through the buttress and then widen it out and create a nice wide arch. When doing these, if we only want 6, 8, 10 millimeters, then this is sufficient. If we want more than that, we're going to go into a full Lefort segmental type of surgery procedure. We might do TADS and MARPE to get 6 to 10, but if we need a lot more than that, well, then we have to really lean toward the full surgery. So we can do a lot of things with these SARPE release procedures, get nice width, nice change. And then again, here on the lower, notice the lower removable appliance. It's a Schwarz appliance, and it's not Schwartz. There's no T in it. It's a Schwarz. It's from Germany. And so that screw is typically at the midline from the lab, but we have it made off to the side. So if the upper is being widened more on one side, that lower has to widen more and decompensate more on one side. So the screw is put to that side. Okay, and we get the width. So we'll jump through this. And then we come back and superimpose and measure what the net gain was. And so again, here's the piriform release. When it's done, there's a little suture up there and it's free. And that whole crossbite side can widen out now and become a normal symmetric arch. And how wide is wide enough? Aesthetically, when we look at that clinical guide, we actually want to see the mesial buccal of the first molar. We want to see the first molar in the wide smile on a brachyfacial pattern. We want to see a nice wide arch. And that's an aesthetic guide for us. We don't want to see side teeth leaned in. We want them upright like the pillars of a Colosseum, just nice and wide and symmetric. And so looking in the back, the most posterior tooth in the smile should be upright. And if it's a tapered face, you're probably going to just see to the second premolar, but it should be upright, not leaned in. Nice and upright, gives that nice facial support, and visually there's a beauty to that. So it's a perpendicular axis that we want to see. Example, this guy was finished, flew in from Utah for his treatment. And in the Marina especially, we had about 2/3 adults, but out of those, at least 25% were commuters or out-of-state patients that came in for years. And I remember back, it was like the golden age of jaw surgery in the 80s and early 90s. Insurance covered it really well. Bruce Sanders and about 8 other surgeons and us in the area, we did at least 100 cases a year of orthodontic surgery. So it gave us a lot of experience and a lot of learning because the cases coming in were failures. We were kind of the dump. If somebody was having problems or in our area that wasn't working out, then we had the cases come in. And it was a privilege because with every case that was kind of not well treated or it couldn't get treated properly or well, it gave us something to learn. And so I appreciate that experience. But this guy's Utah, and he had some teeth out on one side. He's asymmetric, a narrow smile, but his jaw is the reason. And he snores. So it wasn't a big sleep apnea type need. It was just a snoring condition and a need to change the jaws. So we open space, bringing the arch forward and setting the case up. And I'll tell you a little later, but if a case like this has more severe apnea conditions or other conditions that are not just life-threatening, but are just life-altering, we'll operate first. So I highly believe in surgery first, because when we get the jaw parts aligned and the patient thriving and doing well, it's easy to line the teeth up. So I'm not going to put a patient through 6 months or a year getting ready for surgery and struggling all that time. We're going to go and change it to the priority is let's get your jaws and function and sleep first, and then we'll come back and get the teeth lined up. So we can definitely do it that way. So it's a priority. There's a 3D analysis that's in the software. So it's our frontal analysis, and we can rotate the volume to find the landmarks. I would encourage you to use less landmarks than more, because there's a lot of landmarks we don't change with our treatments. So why sit there and measure all those if they're not going to influence what you actually do? But you need to have the planes, the midline, the occlusal plane, the placement of the jaws, and where the teeth are. So for him, we're going to open up space, do an implant to replace the missing tooth, get the arches wider, move both arches forward, and you can see the change in his smile. And he sleeps well, and mom flew in for the day. He's getting braces off and all that, but it's about a year and a half. But the main thing here is the buccal corridors. You see the last teeth nice and upright, big wide arches, nasal breathing, and a happy guy. So Matt, good guy. All right, symmetry. Isn't it fun to look at ads? Most of the watch ads are symmetric, 10 and 2. And lately, the minute hand is a little bit before or after the 2, but they classically are at 10 and 2. So the people like harmony, they like beauty. And when we look at the side of the face, if we just have cephalometrics or side views, we know the height, we know the length. We do not know the transverse. So we've got to have something from the front to understand the asymmetry or the tip. And so I love the coronal view and rely on it. And the coronal view gives me the midline, gives me the nasal chamber, all the turbinates, everything about the facial 2/3, the maxillomandibular components, the tip to occlusal plane, the midline. Mariano Rocabato, who's a good friend from Chile, the physical therapist, was the one that was visiting the office. He actually came in the 80s, wanted to learn how to use a face mask with patients. And we were just on programs together, but he taught me that South America is different as far as the occlusal planes, south of the equator, than us. Our occlusal planes more often are high on the left, and occlusal planes there are more often high on the right. So we had interesting conversations and looking at patients. And when I went there to teach with him, I found that to be true. But Reagan was high on the left, and most of us in America are high on the left, unless we're left-handed. Then about half of them are high on the right. What do patients see? They see the midline if it's more than 2 millimeters off. They see the occlusal plane if it's more than 3 millimeters or 8-10 degrees tipped, and the chin to the midline if it's 4 millimeters or more, they notice it. So 2, 3, and 4. 2 at the midline, 3 at the tip, 4 at the chin. So when we plan our treatment, I've got to get to the front to see these 3 things. And these are what the patient sees looking in the mirror. So it's important to them that as we guide and finish the treatment, that we try to nail it. We try to get those things symmetric. And so Rick did his analysis. I credit Rick for even bringing importance to this and teaching our profession. And it's mostly ignored because it's hard to find the landmarks. Well, welcome cone beam. We can find those landmarks beautifully, or we can rotate the volume, identify the landmark, bring it back, and the little dots there, and we can do the tracing real quick. But you only need a few landmarks to create the information. And when I did the frontal, I didn't want to draw planes across the face because it just says, oh, it's tipped or it's different, but I don't know what's different, where, or how much. So I wanted perpendiculars because the perpendicular comes to the midline, the mid-sagittal plane. And if I look at 2 lines, one line coming from the side of the maxillary component, J point, the difference at the midline tells me that out here in space, they're different by 6 millimeters because that's how different they are. Same at the angle of the mandible or at the chin. So it's very visual and very quick. It was on the cover of our journal in 87. That's when I finally had it done enough that I could support it and publish it. We run a floss down the front of the patient as a visual in the clinic just for a picture, just to kind of have a way to show the patient some things. If it's done through computer programs or softwares, this is all you have to know is locate the 2 J points on the side of the maxillary, the 2 AG points at the angle, the center of the chin, the center of the crista galli, and anterior nasal spine. You construct a vertical, the landmarks out here, occlusal plane, and that's the key part because these are the parts we change: the width, the leveling, and the chin placement. And that's each half of the face then is different, so it's going to get treated differently. On our cone beam, we can sculpt it to see this difference in anatomy. I'm not going to change that unless I have the surgical colleague help me out. There's different values and numbers and measurements. So back then, that's when made it clear to Ricketts and I as we did the frontal. It took us 20 years to trace all these cases, but come up with the data. But that's when it taught us that the wide face, the intermolar widths, and all these differentials are different for each skeletal type at different ages. So there's about an 80% ratio at the upper width to lower width, and that carries through all growth phases. So that's why we kind of still make it important to think of the skeletal type when we're planning our treatment and what our norms are. Another example, we can put acrylic on the palate, use a three-way to expand, but the acrylic anchors more, so the opposite side pushes out more. So if my frontal said one side needs 4 millimeters more, then I'll design my appliance to push out one side more. If the midline's off and I have to move one side more than the other to swing the arch to the midline, then I'll design an appliance with acrylic, but a spring on one side to relocate the side teeth so I can then relocate the rest of the teeth to make it symmetric in the finish. And if it's occlusal plane, then I'll use TADs on the side to assist me in moving everything up or down. So in this example, the posterior segment is being raised, but with the help of TADs as anchors. So I level it, and then all the rest of the teeth are brought into occlusion. So in the end, the patient has this nice, level, symmetric smile. Then I have to prove it. So I would challenge any colleagues presenting that when the case is presented, don't just show me a photo that says, look how pretty it looks. Put the data down. You've got your cone beam, let's superimpose. Put down anything that verifies the treatment that's been done and the changes that we are teaching about, talking about. So from the front, there's three things we do. We superimpose the cone beam or the images, and we want to measure the maxillary width, the occlusal plane, and the chin, because those are the key things we change. The width, the location of the arch, the chin, and then how level is it. So I can do that from the front. Not very complicated. The staff do this for me, and then I come back and verify the points and then learn from it. Okay, so Tom Cruise would be helped a lot with some of this information instead of trying to do it with crowns. So anyway, in the end, I want the eyes level, the smile level to that, the chin centered. And this is hard to do because all of us are asymmetric in some place and to some degree. So it's easier to talk about than to do. We want the width first. That unlocks the mandible so the mandible can come forward. And so if we're bringing it forward, we think about Maras and we think about herps and other functional appliances that we use. But unfortunately, there's a reciprocal force on the midface that push back while we're trying to get everything forward. So we want the condyle and disc to be in the right placement in the jaw, have it unlocked, have it neutral, bring it forward. We want to not just bring it forward, but we want to swing to the midline. So again, here's where the frontal coronal view helps me know where's that midline, where's the occlusal plane. Because when it comes forward, the condyle comes down on the eminence. So there's a vertical change and the teeth separate more on the short side. So if I'm swinging the midline, the condyle comes down the eminence more and the back teeth separate more on one side than the other. So doctors know many times they make orthotics and they're thicker on one side than the other. And that's part of the explanation because one side is more compressed and so it's asymmetric. So I want to correct that from the coronal plane. So I'm swinging the midline as we bring the face forward. So this girl starts out with what would be prominent upper teeth. Buck teeth is what her complaint was. Those upper teeth are almost where I want them to finish. So I'm going to bring the whole lower arch and everything else to it. She ends up with this beautiful face and smile and prominence. So with the herps, width first. So that's what this shows. Jaw forward, but I don't want the reciprocal action of retracting the upper segment. So I'm going to add a face mask to it. Here's the proof. So if I superimpose and I go back and verify, what did I do? The upper jaw, because she's young in these first pictures, but I'm doing the finishing phase on permanent teeth. So she's 11 or 12 years old probably. And so the maxillary component, point A, really didn't change much, but the upper teeth came forward. And we know that normally a herps would have caused the upper teeth to move back. So everything on the uppers move forward. See the red. That's the face mask, bringing the upper forward so that the lower arch could come forward How those lowers come forward? Elastics off the face mask to the upper and to the lower keep both arches forward in the face as we're bringing things to finish. So the face mask isn't for orthopedics for class 3. We're using it in class 2 to bring one or both arches forward. Sometimes we'll have it just to the lower arch in a class 2 division 2 to help the lower arch get relocated forward as we're correcting it. Because the alternative would be typical class 2 elastics to try to bring the two arches to match, but there's an unfavorable effect to the upper from that. So the upper is brought forward and we get that signature smile when it's finished. Okay, so here's a younger patient and he's come in and
Well,
what I'm trying to have here is he comes in, the lower jaws is kind of trapped because of the narrowness and class 2 pattern of the mandible. What do patients say?
my lower jaw feels trapped. To close my teeth all the way, it has to go back. The jaw has to go back all the way, and it just feels crammed back into my head.
So this little guy would be the same if we fast forward 40, 50 years to that lady. So let's get the kid early so they never have to be like she is or was till we've helped her. So there's a class 2 hypoplasia. Let's get the air box working, get the nose working, get all the mile underway, get the airway unlocked, get the mandible unlocked. And here's our basic problem. And he's a little bit older now. And so we're thinking herbs to help his jaw. But when we do the forecast, we can't get there from here. We won't get enough growth, even though he's mesofacial. And you can see the lip pattern, the soft tissue compensations that he has. So for him, we're going to use our subnasale vertical to locate the chin. And for him being meso to brachy face, he's got a square lower jaw. That chin has to end up on the line to be aesthetic. We're going to bring him forward. He has surgery when his lower second molars are in enough that we can do the surgery without risking loss of those molars. We go ahead. But his airway condition is what made it necessary, important to do young. So these are the verifications showing where he was at 11 when we did the lower jaw lengthening surgery, and then at 15. And this is the airway benefits, top, bottom. You can see how it opened up. So it's about 80% better. Look at his craniocervical change. The neck flexion, head extension. Look at the curvature, how much improvement by getting the jaw forward and everything unlocked. So that's huge to me. It's a craniocervical benefit. And then he says he's sleeping good. So let's see what he says. Now he's an athlete. He's active. He's doing things. He's growing because he's sleeping. And what does he say?
Now I can sleep better from after I got this surgery for my jaw.
Yes, and we're so excited because he's healthier, he's more rested, he's doing better in school because he does get a full night's rest for the first time ever.
Could you hear that audio? Yeah, for the first time ever. This is grandmother who's brought him in all these years. But it's just so humbling and enlightening to help a kid like that. Well, when we bring the jaw forward, if the chin is off center, we're going to probably at least talk about modifying the chin at the same time, or sometimes modifying the chin helps us with the airway confidence. And so we'll measure it. We know from sleep literature that changing the hyoid position makes quite a difference in the pharyngeal function, but also lip ability for lips to reach. So we'll take and measure and then bring the chin up a little bit more. And this glossoptosis in the young, the genoglossus advancement really helps because the hyoid comes with it. The suprahyoids and other muscles are influenced. So it helps with sleep apnea. But this is not from ortho literature. This is the sleep literature. And this is what it looks like. And sometimes we'll step it. We'll wedge it open and we'll take bone and fill and use plates and so on. Sometimes we'll step part forward and the chin more yet to get more length and more relocation of the hyoid. So all this comes from the frontal plane. And so for this guy, you can see the jaw's been lengthened and you see the chin lengthened more. Look at his great profile, but the airway went from this to this. And the key here to me is the axial view showing the change in shape of the airway. So it's not as much the numbers as the shape, which permits airflow to be laminar. And he's sleeping great and all those things. So the axial view is what really impresses me here. There's sometimes we need to do both jaws and chin to accomplish a very big change. And surgeons help us beautifully with that. And if it's an older patient that's at almost a crisis stage, we're going to do the surgery first. So this is surgery first, what they say.
Tell us your story. How you doing now?
I'm doing all right. My wife was saying that she can't even hear me hardly breathing at night unless she gets within a foot of me, and then she just hears me breathing normal while I'm sleeping, where prior to that, she had to wear earplugs, she had a fan going, and she still couldn't sleep because it was so loud. And so, yeah, now I'm sleeping. I'm having dreams. I haven't had dreams for years. And so, yeah, it's nice to be getting some rest, and that's amazing. So, and it's only been 6.5 weeks since the surgery.
And tell us what surgery you had.
I had the double orthodontic surgery.
Orthodontic, you got it?
Where they broke both the upper and the lower jaw to pull it forward to give me some airway, and it's just amazing.
Okay, so this is kind of where I'll wrap, and we'll pick it up in our class 3 the next time, Nicole. If there are any comments or discussion we should have?
Yeah, I think when we do the next part, we'll go over the class 3 and then go over questions at that one too.
That'd be awesome.
Great.
Yeah, thank you very much, everybody. And Nicole, thank you for guiding me through this. It's a privilege and an opportunity, and thank you.
Yeah, this is so wonderful, so detailed, just so much information that I'm definitely going to be watching this a few times to keep learning from all this high-level orthodontic information. And I'm excited about class 3, learning more about that and the use of the protraction face mask. It's interesting that it's used on class 2, which is really important for people to know. And I definitely have questions about that, which we'll cover in the next one. So thank you so much, Dr. Grummons. I appreciate all of your time and effort and energy in putting this together.
Well, it's my privilege and joy. We each have a passion for this. And Abe Lincoln said, whatever you are, be a good one. So we're trying.
Be a good one. Thank you so much. I'll see you soon.
Yeah, see you at the top.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.